Good morning to everyone, and just we are in front of the University of FECO and SICS, Dr. Ruchi Goyal and Dr. KPS Murray. Thanks for asking me to say a few things regarding the tips and pulse over the management of the nucleus for FECO sandwich and the FECO section. So, apart from the FECO, the SICS is most popular cataract technique globally now. It is because all the time we do not get the very soft cataract to do, but there are also some hard cataracts. So the small wound size is very important for SICs because it is quite stable, lesser astigmatism, and of course there is an early rehabilitation to the persons. And the case selection should be there before we are going to any of the procedure. The case selection should be good especially for the resident, not for the experts like Ruchi Goyal. He can select any case for anything. But for the beginners, there should be good case selection so that you can have a good internal outcome. So planning of the surgery, already it has been discussed by the incision area, where to make the incisions and what kind of the incision has to be done, and the incision size should be, what should be exactly the size of it. For FECO it is, of course you know everyone, but for the small incision, the more less size of the incision, there is definitely less of the astigmatism. And I would like to suggest one thing, that when you are making the frown incision, the top of the frown incision should be 1.5 millimeter away from the limbus. That is more important. Why we should go for this SICS and this FECO section sandwich or Blumenthal or something? Because there are so many surgeons, they are having a very high working surgeons, they are working in the periphery, rural eye care centers, and of course sometimes there is non-availability of the machine, and sometimes there is a machine they have and the power failure is there, and of course this is the technique which is very much cost effective. And why we should go for the SICS? There are certain conditions, as Ruchi Goyal suggested, that we all the time do not get the very soft cataracts, cataract nigra. I don't want to put energy in these cases. Once you put down the energy in these cases, cataract nigra, definitely you are going to trouble the endothelium. The moment the patient wants more and more from you, and you with the help of the energy and the instrumentation, a lot of maneuvers inside the antechamber, there is endothelial damage, there is a lot of endothelial cell losses there. Definitely patient is not satisfied in the morning. And of course, if you do the ultrasonography and you see that there is a antechamber depth is very less, then in spite of the best kind of halon or viscoelastic, you cannot balloon this antechamber. That time you are not supposed to put your 1.5 millimeter in the second instrument. There is very less space to play inside the antechamber. So when the shallow chamber is there or less endothelial cell count is definitely low, the marked corneal opacity, of course it can be done for the grade 1, 2, 3, 4, and of course Morgan cataract. And prerequisites are there for the beginners. It is very mandatory to have a good dilated pupil. If you don't proceed for any of the surgeries. Especially for the resident, I would ask them to have a very good dilation pupil and massive, and don't hesitate to use the massive amount of the visco, and also halon. You should have a bi-side halon GB. Now see the FECO section. The FECO sandwich technique. The nucleus is sandwich between the sandwich. The nucleus is sandwiched between the two instruments. Now, as you know, for this, the good CC, about 6 millimeters as CC should be there for these cases, and pass the viscoelastic all around, and rotate the nucleus like that, and try to bring it into the anterior chamber with the help of the Sinski or the Orsistito, and pass the visco all around here and there, and also top of it. Now what to do? Once you put the visco between the nucleus and the posterior part of the cornea, put your instrument, which is something like a hook, and press it down, and from the below there is victus, and take it out. This is how it is taken, because sandwich between the two instruments, and it's pulled out. Now the first introduce your hook inside, not wire victus, the victus inside. Only the hook inside, so as to engage this, and pass microvictus behind the nucleus in the space. Nucleus is sandwiched between the two instruments. Full force is applied, pressing the posterior lip of the tunnel. Care should be taken that iris should not come out in any case. If you have a good construction of the wound, then iris will not come out. And see, once you have passing this visco, you will see there is a hydrodissection is also dissection also, the substance is also there. There is one thing, when you are going this we are operating vitrectomized eyes or high myopes or floppy posterior capsule or hard nucleus with low epinucleus cushion. That time, what kind of viscoelastic you should use? Try to do the phaco in these cases, take it out, half of it, and then stop the things and inject with Halon 5, which has a dual property in these cases, because this definitely protects in hard cases the endothelium. It changes its behavior at different flow rates. If there is a flow rate is lower, then it works like a cohesive one, and its flow rate is high, then it works like a pseudo dispersion. And visco adaptive to minimize the posterior capsule. Once you have taken out the half of the nucleus, then stop it and inject Halon 5, and then it becomes a visco sandwich. The whole of the nucleus becomes within the environment of the visco. In the organic cataract, always see the size of the cataract, size of the nucleus. Once you dilate it and puncture it, you sometimes see that the size of the nucleus is very small. Once you in the Morgan cataract, especially, one should be aware about the size of the central part. You just puncture the anterior capsule, milky material comes out, and see the size. If it is very much big, then plan your surgery accordingly. Very big, may go for the incision, SICS. If it is smaller, then you pass the power into it and do the phaco, and still it is very less, then you have to divide it like this. So this is my own technique. When I see the smaller nuclei, then I just break them in the anterior chamber, and with the same clear corneal incision, I try to deliver out with my cannula. This is my own cannula, and this is how it is parallel to it. Go inside, keep injecting the visco, and the fragments, they come out. Sometimes it so happens with you also in phaco. Some material is left. Either it is a phaco, a small part of the nucleus is left during your phaco. Then don't try to take, just put the IOL inside, and with a small kind of cannula, you can deliver it out. And see, there is nothing like vitreous anywhere. The pupil is quite constructed after the carbacol. There is no need of the power in these cases. So phacosection. Phacosection means take out this nuclei into the anterior chamber. Wire snare is passed and rotated in the clockwise or anti-clockwise. And so many, either you can divide it into 2 parts or 3 parts. Here you just see the wire snare is there, and you have in the above video you have divided into 3 parts. In the lower part, this you have divided in lower video you have divided into 2 parts, and this is how you have taken out the one by one. So this is very important, just to see here what is the loop of the wire is stable, and rotate gently to the posterior side. It is very important not to rub against the endothelium. If you rub against the endothelium, you are going to damage it. So in these cases, you are breaking into 2 parts. Again, you see the wire, how it is used. In these cases, the nucleus is again prolapsed in the anterior chamber slowly and slowly, and wire snare is passed and stabilized, and it is rotated anti-clockwise, and the anterior loop is quite stable in the anterior chamber. It should not rub against the endothelium to protect it. To conclude, the good dilated pupil is mandatory, number 1. Clean and small sclerocorneal tunnel at the steeper axis, because the incision I prefer to give the steeper meridian, and complete endothelial protection is mandatory, because you are using so many instruments all together. Either with a hard cataract you can rub against the nucleus, against the okay. And during your procedure, there should not be any collapse of the anterior chamber, and never hit the endothelium by instruments in use. Thank you very much.
Thank you. Thank you, Dr. Dharmendra Nath.